Good evening. My name is Bridget McCandless. I am privileged to get to work at the Healthcare Foundation of Greater Kansas City, and we are one of the partners with American Public Square to be able to bring you conversations like this. Someone said that this must be a very auspicious day because the Royals are up by 10 runs in the first inning. So this could be the turning point for all kinds of things today. But we gather together tonight to have a conversation about how we make our children successful in life and in school and in health and well-being. Part of that success depends on opportunities for them to remain healthy. And we know that too many children in our community don't have access to convenient and high-quality services. Over the past 13 years, the Healthcare Foundation has been able to invest in some of those school-based health services. We've invested about $7 million in schools in the area, a lot of that in mental health services, and many of those dollars went to take care of students who were on Medicaid. So part of the mission of the foundation is to be sure that we are caring for those most in need. We also work hard to partner with our community, and it was obvious from conversations that we had all around the metro that people recognize and appreciate the vital role that schools play in health and well-being. I have a couple of teenage kids. You can probably see my battle scars. But I think kids are facing more challenges now than they ever have. It may be that I'm just acutely attuned to those because I'm living them at the moment, but it just feels like our kids are really working hard to grow up and be good adults. That means that that's a strain and a stress on their parents and on the education system that those kids are spending time in. But schools are also a magical place because they draw together students and parents and educators, and they are an ideal setting to be able to provide some of those healthcare services. Because at the end of the day, we want the students and the parents and the educators to all be successful. So building those schools and school supports under them is helpful. We have been thrilled with the increased attention that school-based services have been getting. However, Medicaid and some of the payment systems haven't really caught up with what parents and teachers already know. And so that's made it tough to get reimbursement and to really build a sustainable model to be able to deliver a lot of those services. So over the last year, the Healthcare Foundation has been facilitating conversations so that school health providers are learning about financing opportunities and financing policies. We've been collaborating with those in the state who are interested in school-based health services. And even though we're in Kansas, I'm a Missouri girl, so I'm going to brag on my home state. We've had a really fantastic development on the Missouri side. The Department of Social Services has been willing to open up the billing codes for Medicaid kids to be able to receive mental health services in their schools, and without it having to be part of an individual education plan. This could be world-changing for a lot of kids who need to be able to receive those services and for the organizations that provide them. So conversations like the one we had tonight recognize both the challenges and the opportunities for us to do a good job of making sure those kids grow up to be successful in their health and well-being, that they grow up to be good adults, and that they also get tormented by their teenage children, and that we are faithful in our obligations to educate them well to be good, civically engaged adults like you are here tonight. So we appreciate being able to partner with American Public Square to do what is important conversation. And I am going to turn it over, I don't see Ashley, there she is, to Ashley Beard-Fosnow, Executive Director of American Public Square.
Thank you so much. As Bridget said, my name is Ashley Beard-Fosnow. I'm the Executive Director at American Public Square. And I would echo a lot of what she said. My other title after 5 p.m. is Mom. I have some school-aged children. And it seems like the last year I've had a lot of conversations with other parents and neighbors about mental health issues in our community and teenage suicide. And so I feel very grateful to be here tonight, and I look forward to listening and learning from our incredible panel of experts here. This is actually American Public Square's fourth season. We've been presenting programs all over the metro, and we are pleased to have a panel tonight here in Olathe. This is our first program here in Olathe, and we're happy to be here. American Public Square is a member organization and relies on the support of its members to bring you these programs. If you are an American Public Square member, would you raise your hand? Wonderful, thank you so much. If you would like to become a member, please stop at the table in the lobby after the program. We'd love to talk to you more about that. I would also encourage you to sign up for American Public Square emails and follow us on Facebook. This way you can receive updates about our upcoming programs. And I would like to especially thank the sponsors of tonight's program, the Healthcare Foundation of Greater Kansas City and Swope Health Services. We also appreciate American Public Square's partners tonight, Olathe Communities That Care, the Olathe Human Relations Commission, C's Multimedia, KVC Health Systems, and the Ball Conference Center. We are live streaming tonight's program via the Healthcare Foundation of Greater Kansas City's Facebook page. That website is www.facebook.com/HCFGKC. If you're not here tonight, you can still submit questions for our panel via Facebook. We're also live tweeting at AM Public Square, #APSKC. Okay, inside your playbill, you should find a question and fact sheet for tonight, and it looks like this. All right, so audience participation is a real thing at American Public Square events. This piece is your work for tonight, right? As you come up with different questions or topics that you'd like to be fact checked, you just write it here on this, and then you'll pass it down the aisles. Folks who are sitting on the ends, you have a very important role tonight, because once you receive one of these, just raise it up, and one of our volunteers will come and pick it up. Tonight, Marla Schulda will be our roving reporter. Thank you, Marlis. And she will come by and pick up those questions, and she will read the question or invite the person who wrote it to read it themselves. We also have our fact checker for tonight, who is Chris LeBeau.
Personally.
Thank you, Chris. She's a retired UMKC librarian, and she'll be doing all the fact checks tonight. There are several members in the audience who are manning our civility bells tonight. You want to give those a ring? Who has one? Oh, come on, give it a go. Excellent. Okay, these will be rung if the conversation becomes less than civil. We ask that you not clap during the panel discussion. And with that, we'll get on to our main event. It is my pleasure to introduce tonight's panelist. Here on my far right is Matt Arnet. He's the Director of Outpatient Services for KVC Kansas. Matt oversees the day-to-day operations of KVC's outpatient therapists, medication management providers, and master's list psychologists for the Metro and East regions in Kansas. Thank you. Next to Matt is Paul Giffin. He has been a school counselor at Santa Fe Trail Middle School in Olathe for 10 years. He also taught school in the Kansas City, Kansas schools for 10 years. Thank you so much for being here. Next to Paul is Steve. Steve Arkin has been a staff neurologist at St. Luke's Hospital of Kansas City for 24 years. He is the co-founder of Speak Up, which stands for Suicide Prevention Education Awareness for Kids United as Partners Foundation. And last but not least is Alexander Gianikas, who is a behavioral health clinical substance use counselor at Health Partnership Clinics, Olathe Clinic. He's been practicing in the mental health field since 2009, working in the greater Chicago area before coming to Kansas City. Welcome to Kansas City. We're so glad you're here. All right, and we will begin with our questions. The first question for tonight is for Matt. Matt, what can you tell us about school-based mental health services?
Well, I've seen those services play out in a lot of different ways. And so the way I look at school-based mental health services, it's really on a pretty wide spectrum. And so you might have a specialized program, kids that are on individualized education plans, kids who need more individualized education and care, and so there might be mental health services attached to those specialized programs. You might also see mental health, school-based mental health play out in having a quality referral source in the community, so getting community partners from clinics and other agencies in the area that can help fill in the gaps that the school's not able to, so being able to have a trusted resource to call whenever you have a child who's struggling in school, clearly has a mental health issue, depression, anxiety, whatnot. And then at kind of another level, school-based mental health, at least the part that I'm most involved in with KVC, is educating school counselors, teachers themselves, other community members who interface with the school, everyone from the custodial staff to the nurses, to understand the impact of trauma, adversity on children, and how that plays out during the school day, how that limits their capacity to learn, and helps explain some of the behaviors that you might see at school. So it kind of goes from the direct care level all the way to the community level for me.
Alex, do you have anything that you would add to that? What school-based mental health services, what are they?
Well, so I'm representing Health Partnership Clinic. My colleague, Dr. Moore, is a school-based psychologist who works with our clinic and also is present in Olathe and North and East high schools. So for us, school-based health kind of is this bridge between the counseling and the services that she's providing to those students in those high schools, and then kind of helping bridge them into clinic services such as medical, psychiatric, or dental health.
Okay, that makes sense. Let's hear Paul. You have been a school counselor for more than a decade and a teacher for 10 years. Why do we need these services?
There's a wide range of customers that come in the door. You make a phone call, a referral to a parent, and some parents are jumping on it ASAP. They are looking through their insurance, they're looking for referrals, and they're on top of it. There are other families that you are pushing and shoving and trying to hold them accountable. All of a sudden they're going, and then 3 months later, the child hasn't been seen for 3 months. Life has caught up with them. They have 1,001 excuses why we can't go, and it kind of qualifies as a case of neglect. And school-based services is a way to take the excuses out of the equation and to make sure that that child is receiving services.
Has the need for these services changed over the years that you've been in education?
Yes, this was when I was teaching. This was not an issue. It was simply a referral to that child is seeing someone out there, and they were pretty severe. They were somebody that you might visually, the eye test. They would fail the eye test, and you would go, "That's probably somebody who has emotional issues." That level to now students who do not readily manifest emotional issues that need services that beyond just a friendly teacher and those kind of things.
Interesting. How are these services different from what school counselors do? School-based mental health services. How's that different from what?
Sure. A school counselor deals in three domains: vocational career, social emotional, and academic. Social emotional is just one of the three areas we work in. Going by the traditional model, our purpose is to triage, to take care of the presenting problem, and then to refer out for long-term care. So they will tell you in school counseling programs, you are not there to do long-term therapy. That is not your purpose. And there are not enough hours in the day for us to provide those services.
Excellent. Okay, Steve, your personal story led you to become an activist in this area. Can you tell us your story and what you're hoping to achieve?
We are survivors. We are suicide survivors as family members. Our son, Jason, was born in 1994, and he was exceptional. And he was a National Merit Scholar finalist. He was in the top 1% of his class. He was an Eagle Scout. He won an Optimist Club. He won debate awards. But he also harbored something behind all that, which was depression, anxiety, and his perfectionism. And what happened is that we learned about that when he went to a program that was somewhat similar to this and talking about people's emotions and suicide. And he came back and said, you know what, they're talking about me. And so we took that extremely seriously at the age of 12, still in grade school. And for 9 years, we struggled with him, lived with his depression and his anxiety as he put on a face of exceptional academics and the ability to understand what other people were going through. In fact, at his funeral, people were able to tell us that he was able to understand them and actually save them. He died of his first suicide attempt at Northwestern University. He was an engineering student in the dorm. And he basically gave us some warnings. And basically what we're talking about today is educationally based services, and they are available and they are getting better. And I think that that is extremely important, and one of the things that we want to express upon all of you as being extremely important. And so we developed, after he died, this program called Speak Up, and talking about bringing education, awareness of mental illness and of mental wellness into the school systems throughout the metro and hopefully beyond eventually, in a program called UBU, which is about being an individual and being the best that you can be. We can't be the best, we can't all be perfect. That's impossible. So that's what we're trying to bring about, and to bring everybody together on the same page, educate people about what these diseases are, so that when they're confronted, we can be partners and be able to combat it.
Why is it beneficial to bring these programs and services into the school? Why is the school the right place?
The school is a component of a kid's life. And sometimes there's data that suggests that kids are not comfortable in bringing it to their parents sometimes. That they will bring it to other areas, the church, the school, their friends. And we have to tell people that it's not just the stigma upon the person that's being affected themselves, but also the people around them, so that we look for it in the people that we know. We're going to school with them every single day, these kids. And we have found out that the kids they're interested in that because they see people around them dying. And so I think it's important that we bring about a community within the school of students and educators and support staff to be able to not only recognize but know what to do in these crisis situations.
Paul, I see you nodding. What would you add?
I think, unfortunately, the schools sometimes are part of the problem. That it's the culture of the school, it's the pressure of the need to achieve. Those things are all present. I think having services in a building brings you closer to that source of the problem. Even if it's not communicated, I think there's power in proximity. That you're there in the school discussing those types of issues that may have their origins in the building. And then consultation, given the proper HIPAA releases, is much easier to achieve than me calling up some office and faxing them a release, telling them that, and then I get their release, and then I have to link up with their schedule, and we collaborate. So that collaboration is much easier to achieve and to pull off.
Steve, can I ask you a question? You said that kids are seeing people around them dying. How is that impacting this generation of youth?
There's so much pressure on kids these days. There's so much pressure to succeed. When we saw what our son had written on the computer after he died about how he thought he was taking away more resources than he was able to give back, That was devastating. But I think that that's the way that kids are thinking these days, is that if they don't succeed, then they've failed, and they can't bring down the bar. So when people now are dying, I think that the media now is now representing that these are not accidents and that these are preventable. But the only way to prevent them is by speaking up and being able to be heard and to not be afraid of the consequences, of the ramifications of being that person, losing friendships. I think that the kids nowadays, they understand that maybe they could have done something a little bit different.
Thank you. Alex, can you tell me a little bit about your model? Can you describe the model health partnership clinic and the school's HPC works with used to deliver mental health services to students? What are you doing?
So we have our home office is here in Olathe. We have offices also within, like I'd mentioned, with our psychologist, Dr. Moore, at Olathe North and East, and where she is regularly there seeing students. We also have a clinic in Miriam Park, at Miriam Park Elementary School. So the difference there between what we're doing at the Olathe High Schools and in Miriam Park is in Miriam Park we have primary care providers and dental providers that are actually providing services on site to students in the Shawnee Mission School District. So what ends up happening often is these students are first seen either at Miriam Park or at Olathe North or East, and then they are able to integrate into our home clinic at Olathe for more detailed services if needed, or we can refer them to other agencies.
What percentage of the student body received these services at the school?
It's a very low percentage. Yeah. You know something that's become very apparent to me in collaborating with my colleague, Dr. Moore, she had told me that basically there are 2 to 4 counselors and psychologists that are serving up to 2,000 students. So what we're seeing is that the students that are maybe having a quieter struggle, who are not maybe as visibly struggling, maybe, in the way that maybe a student with special needs may be, these other students are suffering silently. So, one thing that we think would be extremely helpful is, kind of as the panel has been discussing, just increasing awareness and potentially even increasing screening of the other students, in any way possible, because we are missing a lot of students.
Okay. You said there's 2 to 4 counselors for 2,000 students? That just blows my mind. Is there a need for additional counselors?
Definitely.
And why aren't there more than 2 to 4?
Well, obviously funding is consistently an issue. For our specific program, our Dr. Moore has been able to expand her services because of funding through the Olathe Public Schools Foundation. So her position began as a grant. So often, that's what we're finding is the challenge, is how do we create these positions and then sustain them financially.
And then what would that screening process look like? You talked about screening the other students so that there would be better access to these services. How would you screen other students?
It's a good question, and it's very difficult to answer because when we look at the reality of, there are all of these students in a classroom and teachers are overworked and doing everything that they possibly can already. It's really, I think it comes down to looking for the signs, because we can't administer a screen to every student. But, I think that sometimes there are signs that may be missed. Again, teachers and administrators are doing their best to identify those students that are being affected by mental illness, but, anything that they can do to be more attuned maybe to some of the other factors that are not directly relating to academic performance, because that's another issue, that if academic performance isn't affected, that sometimes if the student is not visibly struggling, they're overlooked. So kind of looking beyond academic performance as a indicator.
Okay, thank you. This is for everyone on the panel. My question is, are there other models out there? So we heard a little bit about what's happening at Olathe. What are some other ways that schools are providing school-based services?
Well, I can speak to some of KBC's experience with school-based services. We've done it a couple of different ways. We had a grant program a few years ago with the Independent School District in Missouri, and what we ended up doing with that program was we embedded therapists and a medication provider into the alternative school to start. And so those students who we already knew were high-risk kids, they were kids that were being removed from their home schools, that had issues so severe that they were disrupting classrooms, they had specialized plans. And so we started there with psychosocial groups, meaning that we talked through topics like managing anger, how to identify positive behaviors, support systems, safety, that kind of thing. But then we also partnered with all of their social workers, and we were able to build a network where they could refer kids that they'd identified as either having home factors that were concerning, so homelessness, not having enough food to eat. If someone at the school knew that parents had just lost their jobs, they were at high risk for having truancy issues, then those social workers could work that side of things, helping with hard goods and helping to connect them with community services to stabilize the home. But then they would refer over to us to do work with the kids in the school during the day and then do family therapy in the home at night. And so for me, that's a really promising model. It is expensive. That's what we learned through that project, is that those kind of robust programs take a lot of funding sources to make it work. Medicaid and insurance is just not quite yet caught up with what we're learning about childhood adversity and what that does to development. And so that model, I think, is amazing. I've also seen some integration in other districts where you take positive behavioral supports, which is a behavioral-based model, and then trying to infuse that with mental health counseling, more traditional talk therapy, and trying to pull the parents into it. I've not yet found the magic answer down the street that's solving all of these problems. There's bits and pieces that I've seen really promising work in. And again, like I said earlier, it takes a community to come around this, and so it's not like a handful of therapists are also going to just solve this issue. There's a lot of people that have a lot of eyes on our kids, and those are all the people who need to be helping. Everyone has different priorities when they're around kids. Some is education, some is providing spiritual support, some is providing skills in dance and music and sports and debate and all those things. And so all those people can help.
Alex, I'm going to ask Alex one more question, then we'll take some audience questions. Okay, as a practitioner, what do you see as the major mental health issues facing children and students?
Well, we definitely see issues that we see in the adult population, such as depression and anxiety, unfortunately, suicidal ideation. We also see, trauma, and that is a major issue in terms of creating safe spaces such as trauma-informed spaces to address those issues, because unresolved and unaddressed trauma can definitely manifest in these conditions, such as depression and anxiety later on. So we see that much of the time, as an issue earlier in life in the kids. Yeah.
Gentlemen, can any of you weigh in on this question? What are the major health issues facing children and students today?
I would say it's anxiety and isolation. The student who is isolated is almost doomed. The walls start closing in. They don't have a network of support. They don't reach out and reach out to an adult, reach out to peers, and that's where you see behaviors that are harmful and unhealthy, and it's a slippery slope. Yeah.
Thank you, Paul. Matt, can I ask you a question? You were talking a few minutes ago about pulling parents in. Mm-hmm. What would that look like?
for us, it was about trying to really focus on engagement. And so actually my role in that program was that I would do an initial assessment with every family who was referred to us. And so it really started from that initial phone call where it's not that you're imposing services on someone, because that also leads to dropout, right? If someone feels that they have to do something, no one likes to be told they're a bad parent. I've got 2 little kids. I'm always hypervigilant. If my kid was a fit in the stores, what is everyone thinking about me as a parent? And so the same thing happens whenever you have a kid who's older. Let's say you take a teenager who is failing classes, skipping school, doing drugs, all these things that we all worry about. And you tell their parents, well, you need counseling. How would you guys take it? Right? It's shocking to hear. It's disappointing. There's a lot of shame still associated with behavioral health, mental health issues. And so what we would do is we would just go and talk to the parents about parental stress. And so we used a parental stress index as an assessment tool that's very conversational. And I would just sit in their kitchen. I would just talk to them. And we would go through these areas, and they would identify what stresses them out. And maybe their child's behavior is number one, and maybe it's worrying about finances. And so we were able to engage with them around where their sources of pain in life are, not what we assumed they would be. And that is what we found to be most helpful with engagement. We had very few families say no to our services. Most of them would at least allow us to meet with their child at school, and once they learned that we weren't just going to call the state and try to get their kids removed or do all these other things that are a worst case scenario, they were willing to work with us. And so the whole team kind of moves in that same direction, where it's a non-judgment thing. It's an understanding that kids do have tons of challenges. Some kids respond to those in ways that are harmful, hurtful, or isolating. Other kids have a lot of people around them to help, and so they're able to get through that adversity. They're able to be resilient. And so I feel like that's the piece that's really critical, is that it's not like an ordered thing for them. They have to feel like they are being helped and supported by all of these people saying, hey, we're seeing something that maybe you've missed because you're so focused on all the things going on in your life.
I love that. Thank you. Okay, let's turn the floor over to some audience questions.
And they are coming in, so thank you
Good,
guys.
thank you.
We'll
Keep it
hands up
coming.
with your question, and we'll get around to grab them from you, so thank you. We have a question, and I'm going to tie it in with something that was written as a fact, because I think they kind of go together. The question is, do we have a shortage of mental health professionals in the KC metro area? Psychiatrists, psychologists, therapists, counselors, social workers. But then somebody else also said there are 4 Olathe high schools that have 5 counselors each, 1 school psychologist, and 1 half-time social worker. So I think the question could go towards the metro area and within the schools. Is there a shortage?
Who wants to start?
I'll start.
Thank you, Paul.
First of all, a school psychologist is not a true psychologist. They are there for educational learning and testing. They usually are a part of the special education department. So while they can provide services, that is not their primary position. So lumping them in that equation is probably not appropriate. 5 divided by 2,000 gives you a ratio of 1 to 400, which is better. We just increased it from 4 to 500, 4 to 5 counselors in the last 2 years, I believe, and that is close to ideal. The American School Counselor Association recommends a ratio of 1 to 350, 250. 250, thank you. My boss is in the audience. And 1 to 250, but practically speaking, that is hard to find, 1 to 250. 1 to 350 is a pretty good number starting out. But how do you get access to those kids? How do you find out what they're thinking, what they're doing? And even if you have somebody in therapy, there are no guarantees. That child is seeing a therapist every single week. There are no guarantees that they're isolating themselves from the therapist. How much are they sharing? How much true help are they getting? It's a scary deal. And you hope that you're visible and you're accessible, that students are comfortable coming in and talking to you, self-reporting, reporting a peer, that teachers are tuned in. And I would tell you, teachers are now hypersensitive, almost to the point of over-reporting things. That if they see a drawing, if they see the word kill in a writing piece, they are quick to report. They are very quick. A lot of times teachers or PE teachers will be having discussions or reflective writings, and that will generate 2 or 3 referrals there. So those are all, yeah.
Steve,
I was going to add a little bit of a personal anecdote to that type of surveillance. Jason, during freshman year of high school, was asked to what he would change. If he would change one thing, what would it be? And it would be his perfectionism. And we found his essays the day that we were preparing for his funeral. The reason being is that it was part of a school project to see, well, how does the writing change over the 4 years? And I think that it would be important from an access standpoint and from a HIPAA standpoint to allow the teacher who sees that to be able to act on that. He had mentioned things about if I was not perfect and people would be laughing at me, it's should I've even been born? So I think that is the type of language that would raise some flags to what you were saying. I think it's important about peer-to-peer relationships and knowing exactly what to look for, not only what people are saying, but how they behave. Are they acting differently? Are they isolating in the lunchroom? And that if your peers are educated in that situation and know where to turn from an adult standpoint, and the educators are experienced in knowing what to look for, then you can identify these people earlier. The stigma really is about, so what is it? It's a disease state. I'm a neurologist. I'm not a psychiatrist or psychologist, but I can tell you it's the way the brain perceives what's happening to you, and the brain is telling you that you're inferior and that you'll never be what you need to be. You'll never be the best. And it's that type of information. It's not a character flaw of the person that's affected. It's not a character flaw of the parent that is trying their best to understand what's happening to their kid. So that if we all work together from a school standpoint, from a parent standpoint, through the identification, these people are brilliant and they have so much to offer, but they're stifled by their disease process. So I think all that we've been saying is about education and about not being afraid to say something about it.
do kids and teenagers know what to look for? You're talking about peer-to-peer identification. Does the average kid in high school know warning signs that they should identify to an adult?
Or do they have the courage to report what is a completely obvious situation where I share with a friend, this is what I'm thinking, this is what's going on in my head, and you and I would look at it as a third party and go, that is an obvious reporting situation, but would a friend keep that confidence? Would a friend be afraid to report? So one of the things, at least in our district, we really push is the need to report, and obviously the clearly obvious situations where someone's saying, I'm thinking of this, I'm planning this. Yeah.
Our program is all about collaboration.
Yes.
And it's about teaching everybody on the same level. Kids are very knowledgeable. Yeah. They want to protect each other. Yeah. They really do. I mean, they're brought up now to compete against each other.
Right. But is that protection, I'm protecting the relationship between you and me by keeping your confidence, or do I see the bigger picture and say, I need to protect you by reporting to the third person?
And we talk about that all the time. It's like, well, do I lose my friendship with Tommy, or do I save his life?
Exactly.
And what's the answer? What do the kids that you talk to say?
The kids I talked to recently are saying that they protect their friend's life. I think they understand that they'll come around. I mean, kids' brains will mature and eventually solidify at around the age of 20 or so, and they will figure it out. It's like, oh my gosh, my friend saved my life. Right. I think that's the important thing. They don't recognize.
Why did I share it with you in the first place? I chose you and I shared it with you, secretly hoping you're gonna give me some help.
That's right.
Yeah.
It takes so much courage for them to be able to say anything.
Yeah.
They're afraid of what the answer is going to be. And what we're trying to do in collaborating with all of you guys on the stage here is to try to figure out a way to empower the kids to get that information, even if it's nonverbal.
True.
I think, too, it's all about feeling safe and that the person you're talking to is accessible. So as you guys were talking, I'm just thinking about, so the thing, I teach music outside of my work here at KVC as a clinician, so I've taught high school students for about 20 years, And it's always been sort of my getaway job where I get to go and be creative and teach music and work with kids that don't have such acute issues. Here's the reality, those kids have just as acute issues as the kids that I work with in foster care here that have documented trauma histories. And those kids over the years have routinely talked to me about kids that they're worried about that I teach every day that even I didn't catch. Because I don't spend the hours on social media with them. I don't sit on the bus with them on trips. I'm not in classes with them 8 hours a day. And I'm a trained psychologist. And I didn't know that I had a kid who was suffering from such severe depression that he was thinking about taking his life last year. It took another kid coming to me and saying, what do? I gave him some ideas, and then the kid himself was able to come to me and say, I need some help. Will you talk to my parents? And so it's this weird crossing over of roles, but I think it illustrates perfectly that even with all the training in the world, the kids, that's their ecosystem, that's their entire world. And they need to feel like the adults around them aren't going to judge them, that they're there to help them, and that their friends are there to help them too. But those friends have to trust the adults that they're going to take that information and actually help. And not just slap a kid on medication or force them into services that they don't want to be a part of.
Thank you. Can we do another question, please, Marlis?
I'm holding 6 questions here that want to know about social media, the impact on our kids, what can we do to help? That's what they're all about. So
Great
take
question.
it. Yeah.
Who wants to start? Social media, is it having an impact on teenage mental health?
Huge.
Huge.
Yeah, how much time do we have? Like 3 more hours? Scratch the surface a little bit?
Yeah. We can throw that issue under the bus and call it the evil of this generation. It is socially amongst your peers. It's required. It's required that you be active and that you be connecting with your friends after hours. And the popular kids are all doing it. And unfortunately, it can be a savage world. And anonymity breeds another level of boldness and lack of empathy, detachment. I don't have to see you bleed when I cut you, and it's hard. And the thing that scares me right now is that the level of predators out there and the vulnerability of our students and the skill of the predators in manipulating them.
Are students more vulnerable than they have been before? Or just on the online space, is that?
I think they're vulnerable, yes, because are they more vulnerable? Yes, I think so. I think so, because they turn to the internet for those things that are missing in their lives, and the predators are so skilled in manipulating and exploiting those openings, and it's very scary.
Social media, who else has some input?
I mean, I think we can see even just in the last several years how there have been more and more sort of apps and websites that are developed to kind of fit every single kind of pocket of a person's life and the way they communicate. And so it becomes this kind of inescapable process where, these kids are involved on 3 or 4 different mediums communicating, and it's this overload. And there's really, they never get away from it. And that's the part that I think is so incredibly dangerous, is that even when they go to sleep, there's still communication, the things are still happening, and they wake up and there's more messages and there's more, just never pauses. And that's a unique problem that we have, I think, in this society.
Can I get some free advice? What would you tell a parent of preteen children?
I think you have to set limits early. I mean, this is something I'm thinking about with my 3-year-old right now, because he wants to watch videos on a tablet or on a phone. I mean, kids now, it's ubiquitous, it's everywhere. Kids they're so easy to use the devices, and it's so easy to fall into a trap and end up being exposed to things the kids' brains aren't ready to process yet. But even when you're getting to those older years, I mean, whenever I was growing up, if something happened in the playground, you got called a name or something, it took a while for that to kind of spread around, and it would die out almost as quickly as it started. There's staying power to that bullying and that kind of pervasiveness of what's going on, because it's not just hitting a handful of kids. It can easily be blasted out to an entire class at a school within minutes. And so you have the kids that are on the victim end of that, but then you also have the kids who maybe don't have access to it, and then they get left out, and they don't feel like they have anyone to connect to because maybe the limits are set way too high for them, and so they have maybe zero access to that. And so they're missing out on this whole new sphere of social interaction that's kind of developed in the last 10 or 12 years. And so I think if you set the boundaries early and talk about the safety issues and know that there's some people out there that aren't who they say they are, and you practice through that stuff, that certainly helps. It's by no means a complete solution to it. I think the more that we turn away from those things and just hope the problem solves itself eventually, that's when we run into problems in general.
I agree with early that it's harder to bring the horse back into the barn. That you want to set your limits, expectations. This is my technology, I own it. I need your passwords. Your online presence needs to be something that I will be proud of, that you would not be afraid to show me. And then as we build trust, as the brain matures, as they're more socially skilled, then the horse can be let out of the barn a little bit more and more.
I love that. That's so helpful. Thank you. Let's dive deeper into trauma-informed care. Is this microphone working? Can you hear me? No. Hello? Test, test, test. Is my microphone working? Okay, so let's talk about trauma-informed care. Okay, for the lay person, it's been mentioned a couple times tonight. What is it, and why is it important? Matt?
So, okay. Give everyone equal opportunity. So for me, trauma-informed care, again, it has many levels to it, right? So as a provider of trauma-informed services, we have a clinical model that we use that's really kind of operational, where we assess for trauma for kids that we know have experienced a lot of it, adversity, and we have a treatment modality meant for clinicians on how to treat it. Trauma-informed care for me is a broader scope of just understanding the impact of early adversity on healthy development. When you break it down, that's really what we're talking about here. The more adversity kids experience, not having food, having domestic violence in the home, having a parent with severe mental illness that's not treated, abuse, neglect, all these things take its toll on the developing brain, and it creates issues where kids go into a survival mode more frequently than they probably should. And that ends up hindering development, which means you might have a kid who presents as a 12-year-old, but their brain development might be delayed, and so they respond to things emotionally more like an 8 or 9-year-old. And so it's not compatible with their peers. The kids start to stick out more, they fall behind in school, and then you have this whole other issue that develops out of it. And so it's not always just the direct trauma itself. Physical abuse is one example. It's what that does for that child over time, and it makes their emotional development so much more delayed than their peers. And so for people to understand that concept, to look for the signs of the results of trauma, and to know that, okay, well, if this child is falling asleep in class every morning, it might be because they don't want to learn and they just want to sleep in class, but there may be another explanation, and the willingness to ask the second question is trauma-informed care for me. The obvious face value is where we get stuck. You've got to figure out if there's maybe something, and maybe there's not. Sometimes you have kids that are they struggle with conduct, they don't want to be in school, but then for other kids, it's about the impact of what they're going through every day that really results in some of those problematic behaviors when they get to school.
So do you think that school districts are successful in
I mean, I've done a number of trainings for districts all over the state of Kansas over the last 5 to 6 years. There's a lot more awareness that that's something that we need to know about, that trauma, early adversity, toxic stress, however you want to frame it, is impacting our kids. There's a lot of neuroscience research coming out that supports that, and there's a lot of answers to questions that for a long time have been unanswered that we're getting now. And so I think that there's a real push to understand what's the impact of not just dealing with things like community violence and areas that are underserved. This affects everyone everywhere. And their studies, the Adverse Childhood Experiences study, is a perfect example of seeing that play out across our country. And it's not just in impoverished areas, it affects everybody. And so that, I think, has woken a lot of districts up to say, we play a role in this too. We need to be aware of it and see how we fit into this puzzle, because kids are here 8 hours or more a day. They see people at school almost as much as their parents.
Paul, I saw you nodding a couple of times.
Yeah, what is the first step of an administrator or a counselor? It needs to be one of, tell me about yourself. That you need a background on the student. You cannot just react to the presenting problem. The student is falling asleep in class. The student is acting out. Therefore, we're going to have, here's the standard response, code of conduct. If this is the situation, here's the solution. You need to research the student, hear their story, gather background information, and develop a relationship with that. If a referral is necessary for mental health services, make that referral. Engage your community resources. It may be bringing in a youth mentor. It may be actual therapeutic services, and develop. Most schools will have a team that deals with student improvement. They may be called the MTSS team, they may be RTI, maybe student mental health team, but there'll be a team somewhere in the building that'll deal with those issues. So call that student to the attention of that team and put them on the proverbial radar and kind of monitor them. Hopefully a staff member, maybe not necessarily even a counselor, maybe an individual teacher or an administrator will take a personal interest in that student and link up with them and make a difference.
Wonderful. Marlis, are you ready for another question?
Yes, it's on, sorry. Since you're talking about some specific things that can be done, there are a lot of questions asking about that. One of them is actually local. It says, I thought I heard of an app by the Overland Park Police or the Blue Valley Schools that lets kids report on things like this, people are worried about, with anybody not knowing who reported it. And then somebody else asked about the SOS program to prevent suicides in schools.
One of the things that has interested us is exactly that type of program where people who otherwise would be afraid to speak up, as long as everybody was on board of what that communication would mean and what the resources would be based on the time of the day, et cetera, that they would be more comfortable in saying that about it instead of being known as to who it was, and then the teacher would be able to go to the person that texted them and be able to converse about it. So I think we've thought about that and have looked into various ways of trying to recognize it.
Brilliant.
There are several national hotlines. I'm not familiar with the Overland Park Blue Valley app. Most schools will have. Some schools will have a anonymous tip line, and certainly counselors have a direct voicemail that can be accessed 24/7, and messages left anonymously on that. So.
I think also beyond any specific app, I mean, the message has to be clear that it's okay that this happens, and that kids, I mean, when you're going through adolescence, there's a lot of challenges. Obviously, we've talked about several personal examples tonight, and that sometimes for some kids leads to thoughts of not wanting to be here anymore or wanting to harm themselves, and there needs to be just an understanding across all kids in a school that it's okay that other students and peers are struggling with this, and that everyone wants everyone to be safe, okay, and to get help. And that, again, it's about what are ways that we can help the whole system destigmatize this idea that if we just don't think about it and don't worry about it, then hopefully it won't happen. That rarely works out well. And so there needs to be not just trainings for, like most of mine have been with teachers, administrators, support staff about trauma-informed services, but there needs to be programs more geared for kids at all levels, and so they understand that feeling that stress and feeling that pressure is a normal part of growing up, and if it gets to a point where it gets scary or some things start to creep in that you're worried about or other people are worried about, it's okay to talk to someone about it. I think even if it's anonymous, kids aren't going to use an app like that unless they feel like it's important that they say something. Because I can say just from my own personal experience, when I've had friends that have struggled with these issues when I was younger, I just also was someone who just hoped eventually it would go away. It's very hard to look in the face. It's very difficult to be upfront about. And so I think that the more that that's normalized across the board, the easier it is. Programs like mental health first aid are great first steps. It's a program, Johnson County has some providers through the government that really isn't a clinician level understanding, but it's like very basics for people who maybe interface with kids and other people in the community to just pick up some of these subtle signs and be able to understand what that means and maybe report it or find some way to help that individual get help. So there are programs out there, even if it's not a specific program like the ones that were mentioned on the card.
Marlis, do you have another question?
Well, to kind of get back, to get a little deeper into that, and those of you who have been involved in the schools, there are questions regarding specifically what things are being done in earlier ages, in elementary schools, in middle schools. Are there things being done to try to address these at an earlier age? And then we have a question from a social worker who says that her services are stigmatizing. She's been told that they're stigmatizing and have been denied consent because of this. Beyond talking about the need for mental health services and attempting to raise awareness, what would be your best piece of advice in terms of overcoming this barrier? So I think people want to dig in a little bit deeper on these issues.
I think one of the challenges that I've personally run into, so for several years I was a full-time counselor. A lot of times it made sense for me to try to see some of my kids at school because they were struggling specifically at school, or maybe that was the only time that I had access to them. Parents, families homeless, something along those lines, maybe it was just the safest option also in some circumstances. See the kids at school. And I think that some of the concerns that were brought to my attention were, well, if we call the student down to the office every week around the same time, people are going to start asking questions, and then are we disclosing protected health information? Are we not allowing this child to go to school and feel like that can be their whole focus here? So there's a lot of concerns that have been brought up around that. I really just would talk to the administrators, the teachers, the people who I felt like would have an impact on this child and help them to see the value of meeting with a therapist, and then during this particular time of day made the most sense. I think having those conversations and helping school personnel to be part of the conversation and not just ancillary, just kind of over here, just give me a space and go do your thing, has been the most helpful. When we do consultations on cases at KVC, and primarily we work with kids in child welfare, that's kind of the focus of what we do. We always try to include school personnel, at least I do when I do trauma-based staffing. So I want to get people that know that kid well at school on the phone so they feel like a valued member of the team. Sometimes that helps to break down some of the barriers to just access to kids during the school day. You can always problem solve around things like, what if people ask questions, or how does the student get to the therapist, where's the therapist housed in the building? There's ways around those pieces, but I think it's part of a bigger conversation that as someone providing direct service, we want the school to be a valued member of the team. We want everyone to sit at a round table and to all have a piece to contribute.
I would say the need to get those people that we're asking the student to trust, to open up to get those faces out there and to be exposed so that a student feels comfortable coming in the door. That means just greeting students as they pass by in the hallway. It means hanging out in the lunchroom, that there's a comfort level there. And hopefully you're there at that building for 2 or 3 years, and people begin to know who you are, begin to develop that sense of trust. Also, you're in the classrooms and you're visible. When you go in the classroom, you're telling them your story, so they're feeling more comfortable and more comfortable approaching you. The stigma is there. When a student is inpatient and they come back, one of my first questions to them is, how will you answer the question, where you been? And invariably, other students will know that the word is leaked out through the network of friends that they are at an inpatient facility. And so then first day, everybody comes and say, where you been, where you been, where you been? What's your response? Do you want to stiff arm them and say, none of your business, I'm okay? Or do you want to tell them the truth? Or how do you want to deal with that? Now, after 2 days, it's not even an issue. not even a question. It's old news and it's forgotten. You know, we've moved on to some other drama, some other story of somebody else. And, you know, so it's a very short-lived stigma. We have an in-building therapist as well, and the location is very discreet. The referrals are made through our office. So nobody knows why little Johnny is called to the library and gotten a pass to the library. Well, there's an office in the library, that's where the therapist is. There's not a big sign on the door that says therapist, caution, and so we don't advertise that.
No, that's wonderful.
Yeah.
Steve, did you have anything to add?
Well, I think, you know, the stigma is still real. That's what we're trying to break. And what we're trying to convince the children and the parents is that these illnesses are real illnesses. They're not makeup, they're not weaknesses, they're not just putting on a show. These people have real illnesses. So the people that have them are afraid of what the consequences are going to be. But if we all understand that, you know, if you see somebody who's having a seizure or having an insulin reaction, well, that's a real illness, come on. But to somebody coming back from an absence, it's like, so what's going on? We want to empower those people to say, you know what, you know, I have something going on that's being actively treated. It's an illness, but I'm going to get through it. And I think that's the key here, is that so far, not only is it the fellow students, but in some ways we're changing it around, but even the schools, the systems themselves, it's like, well, we're not going to talk about this because it doesn't exist, and it certainly does, and you're losing your student population on the basis of it.
Okay, we have a fact check. Research librarian Chris LeBeau.
Actually, Alana had looked this up, but in regard to the question about the app, the Blue Valley School Districts have rolled out the P3 Tips app, and it's from the KC Metro Crime Commission. So if anybody wants to check that afterwards with us, we can give you that P3 Tips app.
Wonderful, thank you.
Also, there was a question about are there shortages in mental health professionals in the KC Metro area, like psychiatrists, psychologists. I don't know if this helps, but there are 830 school-related psychologists, counselors, it's kind of clumped all together, and about 2,450 social workers. So it's the greater Kansas City metropolitan area. As for the Olathe schools, it's you have to look up each school individually. It's hard to tell exactly what the counselors do. Some are clearly educational or college counseling, advising. A couple more psychological, but I'm going where the guest says is right. Thank you.
Thank you so much. Okay. Are there special needs and services for certain populations? LGBTQ, people of color, immigrants? Mental health services.
Definitely. I mean, I can speak to just the Olathe area and the population that we serve in our partnership. You know, there are a lot of Latino patients that we serve. Some of them may be undocumented. Some of them, you know, do not have insurance. And so kind of having the sensitivity, you know, around, you know, the different challenges that they're facing because of some of those factors. So that's definitely, you know, one of the things that we do in our clinic is we have a lot of Spanish-speaking providers actually to try to bridge that communication gap, because a lot of the patients, they want to come in and they're speaking Spanish, and we have a lot of providers that can speak Spanish with them as well. We have interpreter services too, but what I've noticed, I'm bilingual myself, and I've used translator services before because my Spanish isn't perfect, but sometimes I'll use a translator if I need to. But what I have noticed is the difference in that interaction that I have with a patient if I'm speaking to them face-to-face in Spanish rather than using an interpreter. That even if my understanding of the language isn't perfect, there's a connection that is there that's not when we use interpreters. So,
I believe that. Anybody else have something to add?
To piggyback on that, I think what we're going to try to do is to make a bilingual approach to our program and to get to those types of populations. There's data points that suggest that the degree of mental illness and particularly suicidality is definitely different amongst groups, and the ability to approach people of different ideas about what represents communication within the families themselves. I mean, the school is an opportunity there to delve into some things that otherwise wouldn't be brought out, perhaps between friends. So again, based on that, and with the help of all these people on the panel with us, is to identify those risks.
First step in the counseling process is to establish rapport. It is so much easier to establish rapport if you have a commonality with your client.
Going back to that issue of stigma, in some of these populations, is the stigma worse? No?
What I found out in talking to different groups of people in this room, I was talking to Indian Asians who had a different outlook about how parent and kid communication is brought about and what represents the ability to achieve success in an immigrant population, particularly in the United States. And that type of communication is quite a bit different, I learned. Their question and answer session about how the kids are kind of scared to bring up any type of failure. They're brought about to pick an area that they're going to overachieve in. And I think that's very, very dangerous in terms of what failure represents to these kids.
Well, to mention another group, and I don't have a specific statistic, and I'm not going to throw one out there because I don't want the fact checker to check my facts on this. But if you're talking about an LGBTQ population, the suicide risk is much higher, especially in adolescence. And so when I've worked with kids who are questioning sexual identity, orientation, trying to come out to family and friends, you really do have to build a really strong rapport with them. And then I've always found local support groups to assist. The counseling piece is only part of that puzzle. I mean, this is someone really struggling with a core of their identity, and they need to know that there's other people around them to support them through that process. And so when I've had clients who are transgendered and trying to figure out how to talk to their parents about it, there's the Trevor Project, which is a national organization for transgendered people to kind of have a community. There's an online presence. There's providers that use the curriculum and all of that. And there's also some local providers that have support groups and that really focus and specialize in kids dealing with sexual orientation issues or just gender issues in general. And so I always find that it's helpful to have some local experts that you can turn to. I do know, and this is kind of promising in the last several years, there's been more school-based programs kind of pop up where there's support amongst just peers in a school around that same kind of thing. Everyone's struggling with the same sort of issues, and so they're able to find other peers that feel like them and are struggling with the same things as them. And helping them to find those groups of people is really critical to that process as well.
Are these groups that you're describing student organized?
Yeah, I mean, some of them are very loosely, just like through social media. It's just kids that just find a way to, spend time together. It's not like it's necessarily a school-sponsored event where it's like a club and they meet on site or anything like that. I'm sure that some of those clubs do exist somewhere. The kids that I've worked with that have talked about it just say that they are able to kind of work around find other kids that are also, questioning their identity and have some support that's at the peer level. It's helpful to have a therapist and adults and all of those individuals too, but it's never going to feel the same as someone their own age.
Okay, Marcus, are you ready for some more questions?
Yes, Pat from KCMO would like to know, do students need parental permission to receive school-based psych services? And if so, what happens if permission is not granted?
Great question.
Students under the age of 18 are not allowed to engage in a therapeutic relationship. The relationship is technically with the parent and the therapist. So yes, if there's going to be a therapeutic relation, I can talk to a student. I can deal with the problem of the moment, and I can follow up with that. Beyond that, there needs to be a written informed consent or a HIPAA release, as the case may be, for that student to receive therapeutic services. just like it would be if I took my child, my under 18-year-old child, to see any kind of a medical professional, same type of deal. They would need to have an adult there to consent to that relationship. That also presents a problem in terms of confidentiality. I want to have a confidential relationship with that student. So, but I need to get the parent's permission. The relationship is with that parent. That parent can say, I want to know, you must tell me. That's our relationship, I have to tell. Now, am I going to fight that? Am I going to try to persuade the student to talk to that adult? Am I going to try to push back a little bit or hold them off on that? Hey, it's probably not best right now that you ask that question. Can you give me time? Yes, I'm going to do that. So there's a duality to that.
Before you begin counseling, do students know that you're obligated to tell their parents?
If there's a key moment where we're getting to something dicey, yes. I will sit there. I'm not going to say, welcome to my office. By the way, anything you say, I'm going to tell your parents. I'm not going to lead off with that. But if we're going somewhere deep and they say, especially if a student says, hey, don't tell my parents. I'm going to explain, first of all, if you're a threat to yourself or someone else, I definitely have to tell your parents. I definitely have to get help. That's a given. But also if I feel like somewhere down the line, if the parent needs to know, then yes. So I like to say, can you and I have a conversation with your parent? Would it be okay if I called your parent and told them this? So I'd rather phrase it that way and go about it.
You have a very difficult job.
It's exciting.
I have to remind everybody that we did cut it off at 18. At 18, and we did experience this, is that as kids go away from us, that they can waive their HIPAA rights, and that the schools and their psychological services can communicate with the patients, but they need the students' consent to do so. And that is made up front at the orientation of a lot of these schools now, in terms of not only the screening now for mental illness, but also the waiving of those rights. And I think that helps out, and can potentially help out a lot when things change.
Help out meaning you have a significant increase of participation?
I think that the kids who are affected that want to do well academically know that that is part of the equation. And there are data points that talk about that they will talk to their friends first before they tell their parents, even when they recognize that. They talk to high school students and to college students, and some haven't even told their parents yet. That's a good number of people. And so any type of protection that we can get in collaboration, I think is incredibly important. I think that if it is, and I think at UCLA now mandated that on the front side that they go through that type of questionnaire, is to get that information to raise the red flags. And with the parent cooperation, I think we're identifying a lot of people that otherwise would go into school and not realize that. You know, there's about 18% every year, 9th to 12th graders, that have suicidal ideation. And 13% actually have a plan. 8% have actually activated that plan. A couple percent have gotten injured. So those are the numbers that we're dealing with right now. And I think it's very important, as young as we can do it, to get everybody involved, understand that how important this is. People with mental illness die 25 years younger than people without, on average. Not just because of suicide, but because they don't take care of themselves. There's just a huge, vast 20% of us have it.
Those suicide statistics that you just mentioned, have those changed over the years?
They have. I mean, the numbers have gone up about 30% overall in terms of across the board suicide in the United States over the last 10 years. And 10 to 14 age group has gone up 300% over the last 10 years.
And the reason is the things we discussed before: social media, perfectionism.
It's an instantaneous situation. I mean, there's data that suggests that people that attempt suicide that survive, and when they're asked about it afterwards, 70% of them say that they have made that decision within 24 hours of the attempt. 25% within an hour. Okay, so what you deal with on social media is somebody saying, well, why haven't you done it yet? That's the response of your friends. Good friends.
Well, you can even tie that back to, for those who have experienced a lot of early adversity in their life, part of the brain that gets delayed in development is the impulse control center of the brain. So if you have a kid who is old enough to get access to a weapon, a gun, knife, whatever, and has the physical strength to follow through with some kind of an attempt or get access to pills or whatever the plan is, they're acting impulsively like a much younger child, but they have the physical capability of sometimes close to an adult. And so that gap in there, that impulse control can come out in, really impulsive suicide attempt or self-harm attempt. And when we work with our kids that go into our acute care services and they've made an actual attempt and there's been a plan, a lot of times it is just not understanding the broader context. And that impulse control piece is huge, and especially if you're hearing those messages over and over again in a short period of time, your world feels pretty small when you're 15, 16 years old anyway, and then you compound it with these other factors, and then you can have a tragic situation present itself.
I wanted to mention too, if we're looking at other factors in higher risk populations, when we were talking about LGBTQ youth and the higher risks that they're facing just from being, in that population. And then on top of that, the trans, specifically in that LGBTQ group, their rates of suicide are staggeringly high. We may be able to fact check and get the actual numbers, but
it's just 40%.
40%.
How much is substance use abuse a factor in this? Is substance use tied to mental illness or vice versa?
Basically, it is an attempt to self-treat. The mind is going 100 miles an hour in somebody who's anxious or bipolar, and this is the way to settle it down. Talking about it is not going to work because of the stigma that's attached to it. So there is about a 16% concordance rate. 61 million people in this country have mental illness. 10 million people have abuse of alcohol or opioids. And they are directly tied into each other in terms of suicidality too, because when it's overdone and you get that impulsive activity, you got to bring it down immediately, and then you overdo it. So there are a number of people, my gosh, that I've had friends in my age group now with their kids. We don't know exactly why it happened, but heroin, opioids, gone.
I would take it back to the previous generation. Look at the parents that prenatal were substance abused, and was the physiology of that student, that subsequent student, was their physiology altered in utero by the substance abuse of the mother. There's one fact. Then if that substance abuse in either the mother, father, or other family member continuing on as the child is developing, does that raise the trauma factor? Does that all of a sudden we're setting up all sorts of dysfunctional development scenarios for that child? And the learning tapes that are being recorded in the brain are lies, and the things that they come to believe about themselves and about others and about relationships are simple lies. So all of that plays into it.
Absolutely, it's the development in the nervous system that is brought about in utero, and everything that you do will make those nerve endings hypersensitive. So the way that you react to a situation is based on the way that you were designed, and that can be altered by environment. And so there is a biochemical, there's a genetic basis of it, but then the way that things are perceived are based on what happened very early in life as things were developing, as the neurological system was developing.
In my clinic, I treat quite a few adolescents and other young adults with dealing with substance use disorders. And one of the biggest things that I think we can do to address this issue is especially in, the teenagers who are experimenting with substances or kind of crossing that threshold from experimenting into abusing. As much as we want to stop that behavior, we have to try to understand why is it happening. And one of the things that I try to do when I'm working with youth is to ask, well, what does that drug do for you? What does it make you feel that you do not have when you don't have it? And sometimes, yes, they are medicating, a condition, mental illness. Sometimes it's recreational. There's all sorts of different sources that we have to address if we're trying to stop the substance use. But I think that one of the biggest points that I can make to parents and to other community members would be to not get upset, with the child. And it's hard not to, because we don't want them using drugs, but to try to understand and be as non-judgmental as we possibly can. And that's really where I see the most change happen, if we can take that approach.
Thank you so much. So at American Public Square, we always end our panels with a so what, now what segment of the discussion. So I'd like to just go down the line, and first I'd like to ask you, so what? So as we think about the conversation that we've had tonight, what is your summary of the important part of this topic, of this conversation?
For me, the most important piece is that it has to be a community involvement. It cannot just be schools treating mental health in the school day, parents treating mental health in the evening, coaches treating mental health during sports games, whatever. It has to be a whole system-wide approach. And so then the now what is, well, how do we get this really critical information to all of these people, knowing that everyone from a cashier at Walmart to a teacher in school needs to be aware of mental illness issues with adolescents, the effect of early trauma on development, and how do we send it in messages that are easy to understand at a variety of levels of education, of understanding from different populations. And so there's a lot of different tools for that. KVC has developed some quick 15-second spots that run on PBS, the local KCPT station, that just highlight one part of that. Early adversity delays brain development, and then it's just put in a little infographic, or just having these really short, easy to digest pieces of information that help with just education in general, because as we've all talked about, the awareness is step one, and that's kind of the gate to then what do we do about the problem specifically for each individual child and family.
Oh, I love that. Are these commercials on social media?
They're available. They're also on KVC's website. If you go to kvc.org, there's all those resources are available there as well.
Wonderful. Thank you so much. All right, Paul. So what? Now what?
So what? We are now defaulting more and more to the public schools to raise the whole child. Character ed, things that we were not traditionally expected to do in the role of a school. And that now comes down to mental health. Schools are the common denominator throughout our young people. And it becomes, how do we judge a school district to be doing their job? How is that district successful? Traditionally, my son graduated from the Shawnee Mission School District. They're very good, and I don't mean this sarcastically, they're very good at promoting the best and the brightest. They have stories that read, little Johnny did this, little Sammy did this, and here's a superstar graduate in this. And I think most school districts are that way. And but the real mark of a good district is how do you take care of that big chunk in the middle. Not the super bad, not the super good. They get attention as it is, that just by the nature of their behaviors or their achievements. But the invisible middle 75%, how do you tend to take care of them? How do you look out for them? And how do you take care of the whole child? How do you reach out? And to cross maybe a line, how do you minister to them? How do you tend to the sheep that you were given? And that's the way I would look at it.
Thank you so much. Steve?
So I think hopefully my message is all about being able to open the communication. to be able to understand what is going on around you, so that when the kids come home from school, that you are able to and feel comfortable with asking the questions about, so what happened today? How do you feel about what happened today? And get those devices out of there. Go back to basics. When we all grew up, right? We sat at the dinner table and we actually talked to each other and looked for the reactions, and we weren't sitting on our phones. And I think we have to take a look at ourselves and say, so what are we really doing? What are we teaching them when we are doing that ourselves? It's all about education. So my now what is to go home and learn about these mental illnesses, be aware of what's going on around you, and talk to your kids, but also listen to your kids.
That would be the micro, and I would look at the macro as ask your Board of Education, ask your school administrator, ask your school counselor, what are we doing here where I live in my attendance area? What are we doing to help reach these kids? What are we doing? And I can tell you, I have a friend who is in providing mental health services for the state of Kansas. He had to struggle to get into high school to access his client. And so those policies trickle down from a Board of Education to an administrator, to a building administrator, to a counselor. So I would say on a macro level to get involved and to ask those questions.
All of these calls of action have been great. Alex, quickly. So what now what?
Well, I mean, I think my angle on it is integration. You know, integrating medical care with behavioral health services. One of the ways that we do this at Health Partnership Clinic, we have a portion of our, in our electronic record when the nurse is gathering the patient information. It's called Every Patient, Every Time. And in that section, we ask that patient specific screener questions about their mental health. So let's say a 7-year-old comes in who has a cough. We are going to be asking those questions to see if there are any signs of mental illness there. And we do that for, as every single patient that we see in clinic, no matter what the reason is. So that gives us a very quick way to assess for the potential for, other conditions and the need for more assessment.
Wonderful. Thank you so much. I'd like to thank each of our panelists, our roving reporter, our fact checker, and each and every one of you for valuing this topic and coming out tonight. I'd like to say thank you again to tonight's sponsors, the Healthcare Foundation of Greater Kansas City and Swope Health Services, and to our partners, Olathe Communities That Care, the Olathe Human Relations Commission, Seas Multimedia, KBC Health Systems, and the Ball Conference Center. And also thank you to our volunteers and our American Public staff for all of your hard work. When you get home, you're going to receive a survey in your inbox. It's very important that you take a few minutes and fill it out to help us improve upon our programs. And we hope that you will be back to visit us next year for American Public Square programs. Before we leave, my last gesture is a very special gift for each one of the gentlemen sitting up here tonight. These are our engraved civility bells. May you take it with you. Use it as often as possible, especially those of you who deal with teenagers that might come in handy. And that is our program for tonight. Thank you again for coming out. We'll see you soon.
If you don't mind coming in, let me step.